up every corner of my mind. What you gonna do now? Ever since the day you went away, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think about all the nights we were tangled up in your bed. Oh no, oh no, you're going around in circles, got you stuck up in my head. Yeah, memories follow me left and right. Cause you know I have. You take up every corner of my mind. Your love stays with me day and night. Cause you know I have. You take up every corner of my mind. What you gonna do now? Memories follow me left and right. I can feel you over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think about all the nights we were tangled up in your bed. Oh no, oh no, you're going around in circles, got you stuck up in my head. Yeah, memories follow me left and right. Cause you know I have. You take up every corner of my mind. Your love stays with me day and night. Cause you know I have. You take up every corner of my mind. What you gonna do now? Memories follow me left and right. I can feel you over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think about all the nights we were tangled up in your bed. Oh no, oh no, you're going around in circles, got you stuck up in my head. Yeah, memories follow me left and right. Cause you know I have. You take up every corner of my mind. Your love stays with me day and night. Cause you know I have. You take up every corner of my mind. What you gonna do now? over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, no, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think a lot. For the next we were tangled up in your bed. Oh no, oh no, you're going around in circles, got you stuck up in my head. Yeah, memories follow me left and right. Cause you know what I you take up every corner of my mind. Your love stays with me day and night. Cause you know what I you take up every corner of my mind. What you gonna do now? Memories follow me left and right. I can feel you over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, no, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think a lot. For the next we were tangled up in your bed. Oh no, you're going around in circles, got you stuck up in my head. Yeah, memories follow me left and right. Cause you know what I you take up every corner of my mind. Your love stays with me day and night. Cause you know what I you take up every corner of my mind. What you gonna do now? Memories follow me left and right. I can feel you over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, no, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think a lot. For the next we were tangled up in your bed. Oh no, you're going around in circles, got you stuck up in my head. Yeah, memories follow me left and right. Cause you know what I you take up every corner
kamu. Iya, kamu. Dari Bank Syariah Indonesia. Yang udah bareng sama kita. Buat bikin hidup kamu lebih seru, lebih meriah. Bersama biar lebih berkah. BSI Customer Day.
Bank Syariah Indonesia.
Buat kamu. Iya, kamu. Dari Bank Syariah Indonesia. Yang udah bareng sama kita. Buat bikin hidup kamu lebih seru, lebih meriah. Bersama biar lebih berkah. BSI Customer Day.
Bank Syariah Indonesia.
di video kali ini adalah video requestnya teman-teman, yaitu one brand tutorial, lebih tepatnya first impression, karena ada beberapa produk yang gue belum pernah coba. Dari mana? Yeay, bener banget, dari brand lokal Venus Cosmetic. Yang mau gue pakai ini tuh yang 2 cake yang nomor 04 Tropical Beige. Jadi Venus ini punya 3 warna untuk loose powdernya, dan kalau 2 cake-nya ada 4 warna. Ini semua mengandung vitamin E, chamomile extract plus SPF 18. Sekarang gue mau lanjut ke bagian eyebrow-nya. Jadi Venus tuh punya 2 tipe eyebrow. Nih yang versi jadul, dia bentuknya seperti pensil alis kebanyakan, dan yang baru ini depannya runcing, jadi gampang buat bikin alis serat, eles-eles. Gue bakal pakai yang warna coklat, yang terbarunya Automatic Eyebrow. Untuk eyeshadownya gue mau pakai lipstiknya dari Venus. Ini tuh setahu gue harga cuma 30 ribuan loh guys. Yang mau gue pakai ini nomor 15, tuh warnanya kayak merah bata, ya kan? Cara pakainya tinggal ditap-tap aja karena gue nggak mau terlalu banyak. Ditap-tap nih pakai jari gini aja. Tuh dia tuh udah langsung matte. Jadi teman-teman pakainya dikit-dikit aja, soalnya dia lumayan pigmented. Untuk eyelinernya, Venus tuh punya 3 warna. Ini kayaknya model kajol gitu deh, yang diraut. Kita cobain ya warnanya. Ini warna hitamnya, gokil. Ini hitam banget cuy, udah kayak arang, sumpah hitam banget. Ini warna birunya gokil, dan warna coklatnya ini cuman 1 kali gores. Gue mau cobain aja deh warna coklat karena gue tuh sebenarnya jarang pakai eyeliner yang model raut kayak gini. Untuk maskara, Venus tuh punya 2 tipe. Yang pertama itu Ultimate Curl Mascara. Ini yang curlnya. Sekarang gue mau pakein lip creamnya buat di bagian blush on. Yang gue pakai ini nomor 13. Warnanya nih guys, pinkish coral gitu. Untuk lipstiknya gue mau pakai lip creamnya dari Venus yang nomor 16 dicampur sama 15. Gue suka banget sama Venus Soft Matte Lip Cream karena warnanya tuh bagus-bagus, gampang diaplikasiin, terus nggak lengket dan tahan lama juga. Yang pastinya kalau dibikin ombre kayak gini tuh makin kelihatan bagus gitu loh. Dan pilihan warnanya juga banyak. Itu sih yang paling gue suka dari dulu dari Venus Cosmetic ini. Gue juga suka sama eyelinernya. Gila, nggak nyangka banget ternyata eyelinernya bener-bener bold, dan untuk eyebrownya juga enak dipakai sehari-hari.
Memories follow me left and right. I can feel over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, no, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think about all the nights we were tangled up in your bed. Oh no, oh no, you're going round in circles, got you stuck up in my head. Yeah, memories follow me left and right. Can feel over there. You take up every corner of my mind. Your love stays with me day and night. Can feel over there. You take up every corner of my mind. What you gonna do now? corner of my mind. What you gonna do now? Memories follow me left and right. I can see you over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, no, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think about all the nights we were tangled up in your bed. Oh no, oh no, oh no, you're going round in circles, got you stuck up in my head. Yeah, memories follow me left and right. Can see you over here. You take up every corner of my mind. Your love stays with me day and night. Can see you over here. You take up every corner of my mind. What you gonna do now? Memories follow me left and right. I can see you over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, no, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think about all the nights we were tangled up in your bed. Oh no, oh no, oh no, you're going round in circles, got you stuck up in my head. Yeah, memories follow me left and right. Can see you over here. You take up every corner of my mind. Your love stays with me day and night. Can see you over here. You take up every corner of my mind. What you gonna do now? of my mind. What you gonna do now? Memories follow me left and right. I can see you over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, no, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think about all the nights we were tangled up in your bed. Oh no, oh no, you're going round in circles, got you stuck up in my head. Yeah, memories follow me left and right. Can see you over there. You take up every corner of my mind. Your love stays with me day and night. Can see you over there. You take up every corner of my mind. What you gonna do now? Memories follow me left and right. I can see you over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, no, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think about all the nights we were tangled up in your bed. Oh no, you're going round in circles, got you stuck up in my head. Yeah, memories follow me left and right. Can see you over there. You take up every corner of my mind. Your love stays with me day and night. Can see you over there. You take up every corner of my mind. What you gonna do now? corner of my mind. What you gonna do now? Memories follow me left and right. I can feel you over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, no, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think about all the nights we were tangled up in your bed. Oh no, oh no, oh no, oh no. You're going round in circles, got you stuck up in my head. Yeah, memories follow me left and right. Can feel you over there. You take up every corner of my mind. Your love stays with me day and night. Can feel you over here. You take up every corner of my mind. What you gonna do now? Memories follow me left and right. I can feel you over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, no, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think about all the nights we were tangled up in your bed. Oh no, oh no, oh no, oh no. You're going round in circles, got you stuck up in my head. Yeah, memories follow me left and right. Can feel you over here. You take up every corner of my mind. Your love stays with me day and night. Can feel you over here. You take up every corner of my mind. What you gonna do now?
Yang tadi yang habis.
Memories follow me left and right. I can feel you over there. You take up every corner of my mind. What you gonna do now? Ever since the day you went away, no, I don't know how to erase your body from out my brain. What you gonna do now? Baby, we should just focus on me instead. I think about all the nights we were tangled up in your bed. Oh no, oh no, oh no, oh no. You're going round in circles, got you stuck up in my head. Yeah, memories follow me left and right. I feel you over there. You take up every corner of my mind. Your love stays with me day and night. I feel you over there. You take up every corner of my mind. What you gonna do now?
Ladies and gentlemen, and all participants in ICMS 2022, the next session will start soon. Please be seated in your Zoom meeting and please be active the camera in Zoom meeting. Thank you. And now, we would like to invite the third speaker to be able to convey extraordinary knowledge with the theme Perspective of Prevention and Reduction of Complication of Cardiac Illness in the Perinatal Period, to Mrs. Dr. Nisha Clement, Associate Professor from AIC College of Nursing, Bangalore, India. The speaker will be moderated by Mr. Rahman Suleman, SKM M.Kes. To Mr. Rahman, it's your time. Thank you.
Hello, thank you very much. Hello, Dr. Nisha.
Can you hear me, sir? Am I audible?
Hello. Hello. Do you hear my voice?
Can you hear me?
Yeah, I hear you.
Yeah.
Okay, thank you.
Shall I start at the screen now?
Yeah, I can see your video voice, ma'am. So,
yes.
Okay, thank you. Ladies and gentlemen, hello and welcome to the conference on midwife and health 2022 with an absolutely amazing topic, optimizing midwife to prevent non-communicable disease in the reproductive cycle. And
your voice is breaking actually. Can you hear my voice?
Hello?
Can you hear my voice?
Yeah, I can hear your voice. Apologies because we have problem with the microphone. Okay. Hello? Yeah. Yeah, okay. Okay, let's start again. Hello and welcome to the second international conference on midwifery and health sciences, ICMHS 2022, with the absolutely amazing topic, optimizing midwifery services to prevent non-communicable disease in the reproductive cycle. My name is Rahman Suleman, and today I'm going to lead our discussion from start till end. Okay, before diving in too deep, I would like to ask your confirmation, ma'am. Could you please hear my voice loud and clear?
Yeah, I am able to hear your voice.
Thank you. And could you please see my video crystal clear?
Yeah, I can see you.
Thank you. Thank you very much indeed. Okay, before starting, I would like to allow me to read our main speaker's profile. Could you?
Sure.
Okay, apologies. We start to please you to present your presentation, ma'am. So you have 100 minutes to give your presentation, and then 20 minutes later is the session of the question time session.
Sure.
Yeah.
Shall I start my presentation?
Yeah, please.
Thank you, Rahman Suleiman, moderator. First of all, I thank my Lord Almighty for giving me this wonderful opportunity, and I like to thank my principal, Dr. Bharati, and of ESIC College of Nursing, Bangalore, Indiranagar, Karnataka. And I would like to thank the Ministry of Health, Republic of Indonesia, and the University of Politics, M.Kes, Corantello, the director, especially the Muhammad Anas Ansiru, and the association members of International Conference of Midwifery and Health Science 2022 for inviting me as a speaker for this occasion of this conference. So good afternoon, folks. So today we are going to see about the perspective of prevention and reduction of complication of cardiac illness in the perinatal period as part of the sub-theme of the optimizing the midwifery services to prevent the non-communicable diseases in reproductive cycle. So myself, Dr. Nisha Clement, working as Associate Professor in OPG Department, ESIC College of Nursing, Indiranagar, Bangalore, and we are affiliated to Rajiv Gandhi University of Health Science, Karnataka. So let us start this session. The introduction is the global perspective. The pregnancy is always the natural stress test for women with the risk factors who are always predisposed to cardiovascular disease. So there is a need for us to recognize the disease at the earliest and provide an effective and long-lasting strategies for prevention. As WHO already envisioned it, as every pregnant woman and newborn should receive a quality nursing care throughout the pregnancy, childbirth, and the postnatal period. The global statistics says that the cardiovascular disease is a leading cause of pregnancy-related mortality in US. It contributes about 33% and more, and which was found to be cardiomyopathy. The global statistics says that the pregnancies in the late reproductive years are frequently associated with the increased prevalence of cardiovascular risk factors, especially the diabetes, hypertension, and obesity. And in that, about 5 to 10% of all pregnancies are related to hypertensive disorders, which are very frequent in the cardiovascular disorders. And congenital heart disease found to be 82%, and rheumatic heart disease are found to be 89% in all cardiovascular illness in pregnancy. Therefore, it all states that the prevention should be begin before pregnancy, as preconception care, screening, counseling, and improving such the optimization of chronic disease, so that can improve the maternal and the fetal outcome. So mortality rates to be seen in India is like about 28% of death has been increased in 2016, comparing from 1990. So death of cardiac vascular disease in India from the pregnant mothers is found to be rise to 2.8 million. So the prevalence of cardiovascular disease is highest in Kerala, Punjab, and Tamil Nadu. And in Andhra, Himachal Pradesh, Maharashtra, Goa, and West Bengal also having it second with the prevalence. And in Indonesia, the study conducted by Dr. Siatomo Muhammad M.A. found like there are the maternal mortality still remains higher, about 177 per 1 lakh live birth, though there are very good antenatal care has been provided. But then what does it talks to us is the prevention is better than always. So preventive measures should be started in the earliest. So let us come to the part of the perinatal period. What is perinatal? So as per ICD-10 definition and WHO says that it starts at the 22nd completed weeks of gestation and ends with 7 days after birth. So we have to be very careful throughout this perinatal period and help the mother to prevent from the such complications. So before going to that, it is important to learn the physiological adaptations that happens in the pregnancy in the cardiovascular system. And always we know that the plasma volume and the cardiac output is increased about 50% and above, and the diameters of the atrium and the ventricle increases, and whereas while the ventricular function is preserved, and systemic and pulmonary vascular resistance also decreases during pregnancy. To have the altogether picture, like the cardiovascular system changes and its coagulation changes, and the characteristics of the women which act as a factors like increased age, the substance abuse, like including the smoking, alcohol, and vascular and cardiac malformations, having the genetic disorders, hematological disorders, heart illness, acquired heart illness, all those gives a great impact in the maternal outcome, provided there are more pregnancy complications, pregnancy-induced complications also, like hypertensive disorders and preeclampsia, like that. So it is important for us to understand what will be the picture in the pregnant woman with the cardiac illness. And that effect of the cardiovascular physiology on the heart lesion is also important, whereas we should know that normal heart has got enough reserve power so that it will have the extra load can be tackled, whereas a damaged heart with a good reserve can even withstand, but if the reserve is very poor, the cardiac failures occur sooner or later. So it is important for us to protect the mother and prevent the sequence of cardiac failure which can occur during pregnancy, around 30 weeks during labor, mostly or soon after following the delivery. And there are for us to understand the hemodynamic changes is also important. There is a rise in the estrogen and progesterone, which will activate the renin and angiotensin aldosterone system, which will have an impact on the vascular system, and the cardiac output and plasma volume also increases, and there is fluctuations in the BP, which initially decreases and later on it increases in third trimester. And always the increasing size of the uterus can cause mechanical compression in the inferior vena cava during the second and third trimester. That also can impact the cardiovascular status, and also it potentially reduces the venous return, causing postural hypotensive syndrome, and it will lead to a lower extremity edema. So these changes will be amplified when there are multiple gestation also. So knowing these hemodynamic changes happening during the antepartum and also intrapartum and postpartum helps us to provide a very good care to the mother, and we will be able to analyze under which stand she is. So HR, heart rate and BP normally decreases within the 48 hours of postpartum, and BP may increase again because of the shift of the fluids. And it is important as the clinicians and healthcare professional to take care of the mother to prevent from the hypertensive complications, whereas the mother is susceptible for pulmonary edema, especially at the time of delivery and immediately after postpartum. It is important to monitor the atrial natriuretic peptide levels, which will be increased in the maternal plasma. So maternal hemodynamics generally return to pre-pregnancy 3 to 6 months after delivery. Importantly, approximately 20% of women will have diastolic dysfunction, which may return to normal. It's important to know all these changes, all these knowledges, and what will be the structural changes that will be happening in the heart of the pregnant mother. So heart ventricles adapt to the increase in the plasma volume, and whereas from 5.5 to 7 liters, it increases the cardiac output, and ejection fraction varies. And importantly, 20% of women having the diastolic dysfunction at term will be associated with dyspnea on exertion. And let us come to the classification of heart disease according to the etiology. So we usually classify them as congenital and the acquired. Congenital will have the non-cyanotic and the cyanotic illness, as you can see the slide. And then the rheumatic heart disease, which is acquired, cardiomyopathy, ischemic heart disease, and other disorders, which will be causing the heart illness. And these are the classification of the heart disease according to the risk level. Low risk, which is the ASD, VSD, PDA, and corrected FT, and medium risk, and the high risk. So based on this risk level, we will be able to analyze how to proceed with the management. And also it is important to know from this picture the cardiovascular risk factors, like the mother having a sleep disordered breathing, sleep apnea, the use of nicotine in different forms, and uncontrolled hypertension, and mother having a type 1 or type 2 diabetes, hyperlipidemia. So this all will have an adverse pregnancy outcomes, leading to preterm birth, leading to preeclampsia, complicating the pregnancy, and on top of that, the cardiovascular illness leading to arrhythmias, heart failure. So all these are important for us to keep it in mind. And that leads to the complication of cardiac illness like cardiomyopathy, ischemic heart disease, and pulmonary hypertension, and valvular heart disease, and the complications of heart disease in adult and arrhythmias. All these complications in cardiac illness will lead to heart failure in pregnancy. We should be able to in a position to handle such things beforehand. So for all this to tackle, we need a high risk assessment. We call it as high risk approach. So here the high risk assessment can be done using the tool prescribed in Canadian Cardiac Disease in Pregnancy Risk Index. So that talks about analyzing the general cardiac factors and the specific cardiac lesions, and also the modified WHO's classification of cardiovascular disease. With these two tools, it is easy for us to analyze under which category, the risk category, the mother comes under, and what could be the management. So that also being available in the internet. We can go through and we can acquire the knowledge, and we should be thorough how to assess the risk in the mother. And the goal is mainly to provide a multidisciplinary comprehensive plan and throughout the perinatal period, and inculcate such mechanism into the local, regional, and high facility level, and having a referral hospital with which can tackle the women of high risk cardiac illness coming under class 3 and 4. And all these such complex cardiac illness should be handled under the expertise of cardiologists. And talking about the New York Heart Association classification, as they have 4 classification: class 1, 2, 3, and 4. Class 1 with no limitations of physical activity, and class 2 slight limitation of physical activity. The mother may have an fatigue with ordinary physical activity, palpitation, dyspnea, and anginal pain. And class 3 will have a very marked limitation of physical activity, and a simple activity can cause a fatigue, palpitation, dyspnea. Class 4, the mother comes under total inability to perform any physical activity and symptoms of cardiac insufficiency. So it is important for her, even in the rest also, she will have a lot of discomfort. So knowing this class level also is important to understand under which class the mother comes under. This is a very important modified WHO's pregnancy risk classification table. And this, the WHO's risk classification 1, which talks about no detectable increased risk of maternal mortality. The mother has uncomplicated cardiac lesions, which are successfully repaired. So in such case, you can decide where then can be the pregnancy care, delivery location and all. She needs counseling and care at the local hospital, delivery at the local hospital. When she comes to the class of 2, where there is a unoperated ASD, VSD defect is there, and has frequently the arrhythmias, morbidity and mortality level is high. She also needs pre-pregnancy counseling, preconceptional counseling, and always she should be under the consultation with the pregnancy heart team, and a follow-up is strict follow-up is necessary. And class 2 and 3 are having always WHO's modified risk says that intermediate increased risk of maternal mortality is higher. So in that case, the mother will present with a mild left ventricular impairment, hypertrophic cardiomyopathy and all. So she needs counseling and heart team consultation, pregnancy heart team consultation also. If that cardiac complications complicates her life, it's important for us to decide for the termination of pregnancy. So it is important for us to realize this class level and follow this class level, and what kind of impairment the mother has and what kind of guidance we can follow. So that is being depicted in this table. And maternal prognosis always depends upon the nature of lesion in the heart and function capacity of the heart, and what kind of quality supervision, medical supervision, nursing supervision she gets throughout the perinatal period, and presence of other risk factors, whether she underwent any corrective surgery. And it has been found that in rheumatic heart lesions, the mother have less outcome and good prognosis, whereas in mother with cyanotic heart disease, more than 50% of mother have a very poor maternal outcome, and maternal death occurs because of pulmonary edema, pulmonary embolism, active rheumatic carditis, and subacute bacterial endocarditis, and rupture of cerebral aneurysm in coarctation of aorta. So all these things throws in light for us to understand how will be the maternal prognosis. And fetal prognosis, as I said earlier, rheumatic heart disease can be actively prevented and controlled. Therefore, the fetal outcome is found to be good. And cyanotic group, mother has a cyanotic group of illness, the increased fetal loss has been found, and 45% of abortion has been reported, and IUGR and prematurity is very high. And generally, the mother will present with these signs and symptoms. She presents with breathlessness, chest murmurs, which will be pansystolic, late systolic, with a louder ejection systolic, or diastolic associated with a trill, and nocturnal cough. There is a cardiac enlargement, arrhythmias. There will be syncope, cardiomegaly. There is an increased pulmonary vascular markings and enlargement of the pulmonary veins. Thus, she has a chest pain, an electrocardiography showing a T-valve inversion and biatrial enlargement and dysarrhythmias, an echocardiography picturing the structural abnormalities. So all these things are important for us to learn and understand the general management and principles for this, to how to go for this when you encounter such a mother. So early diagnosis and evaluation of anatomical type and functional grade of the case is important. Early the diagnosis, the better will be the prognosis. And then to detect the high risk factors and to prevent the cardiac failure, having a multidisciplinary team approach is always important, which has physician, cardiologist, and neonatologist as a mandatory members, and a hospital delivery is must. And there are certain diagnostic tests which is indicated as explained by European Society of Cardiology. They say the natriuretic peptide level, BNP, brain natriuretic peptide level, should be checked, which will be elevated, indicating heart failure. An electrocardiogram, a chest radiograph, and an echocardiogram is very important to screen the condition of the heart. An exercise stress test is conducted to understand the women's ability to tolerate a pregnancy, and it will test the maternal functional capacity and facilitate the identification of any induced arrhythmias can arise during delivery. So computed tomography is done only if you suspect the mother presenting with a chest pain for pulmonary embolism, or if there is any aortic dissection is suspected. And MRI is rarely done unless until there is a emergency crisis, which has been diagnosed by cardiologists to do. That time it has been advised. And Holter monitor or a prolonged cardiac monitoring is very important. The mother should be under the monitoring cardiac monitoring device 24 to 48 hour. Ambulatory electrocardiogram monitoring is important to assess the palpitations and lightheadedness and syncope during pregnancy. So there are the general cardiac pregnancy is ideally the mother with the significant heart disease should be planned one, should be the complete planning is important, and she should have a continuity of care. That is very important. She should not change the person from one time to another time, and he should be available. The person who she is consulting should be available, and the cardiologist should be an active participant, and you should determine the maternal disease status carefully. Obtaining the history and identifying the other cardiac complications are very important, and you should establish under which classification your heart association classification she come under. That is important. So here are the few important high risk cardiovascular disease which I would like to mention, like pulmonary heart arterial hypertension. If you find it, it is more than the pressure increases 25 mmHg, she is under risk. And then more maternal mortality is being reported. The study says about 9% to 28%. She should be advised for maternal medical termination of pregnancy, and she should be getting the counseling from the health professional to ensure what are the hazards will be there because of continuing the pregnancy, and effective contraception should be educated for her. And if the woman with severe hypertension, pulmonary hypertension, elects to proceed with the pregnancy, because we have to go with the consent of the mother, we cannot direct her to do the MTP. If she proceeds with that, she needs a complete vigilant supervision and medical therapy to continue the pregnancy safely. Now, congenital heart disease. To talk about the congenital heart disease is depending upon the type of the lesion, multiple cardiac structural lesion, and they require a specialized care and continuous strict follow-up. And these are the illness which I have listed here. They should be strictly avoided to get pregnant, like pulmonary hypertension, Eisenmenger's syndrome, severe left-sided heart obstruction, severe ventricular dysfunction, cyanosis, and failing pulmonary circulation lesions associated with the complex arrhythmia. See, the mother with such a cyanotic illness should be avoided to get pregnant, and they should be advised for alternatives. And talking about the non-congenital valvular disease like pneumatic valvular disease with the mitral prolapse, biprosthetic valvular prosthesis, mother undergone such a disease, we should have exercise test, stress test done, and transthoracic echocardiogram done to understand the condition of the heart, and then associated any ventricular dysfunction is there or pulmonary hypertension is there. It's important for us to know the condition of the heart, whether she can be proceeded further for the labor or she can withstand the labor for long. So accordingly, and she will be having, since the prosthesis is there with her, mechanical valve prosthesis being there, she will be under the therapeutic anticoagulation, which carries a lot of risk for the women and the fetus. A detailed discussion about the anticoagulation options and the risk, the frequency, the type of monitoring should be done. It should be best performed and documented, and regular monitoring and medical adjustments should be done to have the proper therapeutic levels. And all pregnant mother, the mechanical and bioprosthetic valves should be maintained with the 81 mg of aspirin low dose, daily low dose during pregnancy. And prophylactic endocarditis, prophylaxis antibiotic should be taken during pregnancy and during the delivery. And if the mother presents with dilated cardiomyopathy, it is important to know the baseline BNP level, transthoracic echocardiogram, assess the ejection fraction and hemodynamics, and the cause of the cardiomyopathy should be evaluated. The mother with the severe symptoms should be advised for MTP, and she should undergo a genetic consultation. Hypertrophic cardiomyopathy is genetic cardiac disease. The complications are very common. Study shows that 2% the genetic cardiac disease is more prevalent, and there is a need for pre-pregnancy counseling, and the genetic consultation is important for her. So, and mother presents with aortic aneurysmal disease and dissection. They are generally sugared genetically, and they are familial, syndromic, congenital. Before pregnancy, a thorough cardiovascular specialty consultation is important to understand the cause, size, location of the aneurysm. So to talk about the atrial arrhythmias, like a mother presenting with such atrial arrhythmias, it is important to undergo an evaluation to find out what is the cause, what is the underlying cause, and why there is a premature heartbeat, and why there is a paroxysmal supraventricular tachycardia. So it can be successfully treated with medications. So point is you have to identify at the earliest. And again, about the ventricular arrhythmias, the occurrence in the absence of structural heart disease, the identified during pregnancy, because it is the body will be sensitive for catecholamine during pregnancy, and it can be treated with beta blockers or verapamil. The risk of ventricular tachycardia especially is more in the postpartum period. So it can be treated with the beta blockers, antiarrhythmic drug therapy, and a possible implantable cardioverter defibrillator is the one of the management. And ablation therapy can be done, should be reviewed. All this should be reviewed. The management should be reviewed and consulted with the pregnancy heart team. And the important cause of the morbidity and mortality found to be the maternal cardiac arrest. The etiologies are found to be, the study shows that 38.1% is because of bleeding, hemorrhage, and 13.3% is followed by amniotic fluid embolism, and 10% of mother with acute coronary syndrome and 4% with venous thromboembolism experience this cardiac arrest. So it is important for us to develop a 24-hour access to the maternal core team. The maternal core team members should be trained all the time, and they should be ready to take care of the mother with the maternal cardiac arrest. So what do you do in that? You provide increased oxygen supply and early intubation with a small endotracheal tube, and aortocabal compression should be done, because this uterus will go and press the aorta, abdominal aorta, that can cause again decreased blood supply. So two-handed manual left uterine displacement maneuver should be performed, so that the patient remains in the full supine position on the backbone to maximize the cardiac compression efforts. And at the same time, parallelly, the preparation should be done to deliver the fetus. And high quality chest compressions on the backboard should be performed 100 to 120 per minute, using the same landmarks over the mid-lower sternum as left lateral uterine displacement is accomplished. Oxygenation is a primary goal. Mother they should get, because another life is dependent on that fetus. So oxygenation remains a primary goal using the ratio of 30:2 chest compressions. So you give with the supplied by bag mask ventilation with 100% oxygen. So this is the management protocol prescribed by American Heart Association. And they tell us to differentiate the diagnosis of maternal cardiac arrest. They are telling us to follow these alphabets, like to differentiate the cause of cardiac arrest. So you can go through that: A, anesthetic complication; B, bleeding; cardiovascular disorder, like that. We have to know the differential diagnosis. Therapeutic termination is from absolute indications, like it should be primary pulmonary hypertension, Eisenmenger syndrome, pulmonary veno-occlusive disease, and relative indications for medical termination of pregnancy will be third and fourth cardiac lesions, and grade 1 and 2 with the previous history of heart failure in early months or between pregnancy. Termination methods can be done by 12 weeks by MVA or manual vacuum aspiration, or by conventional dilatation and evacuation. So this will be the painful procedure to the mother, and psychologically she will be upset to see that the fetal loss is there. So it's important for us to have the grief and bereavement cell with us, so that we tackle the mother and mother does not go for the postpartum depression or postpartum illness. The preventive measures mainly will be the mother should be definitely supervised in a tertiary care hospital where all kind of facilities are available for the mother to be treated. And initial from the beginning itself, the cardiologist should interfere, and during the prenatal care she should be having a thorough examination, and she should have a antenatal card. So in India, here in Karnataka, we have what is called Thai card. We have a separate card maintained. So once for all, she has been booked. She continuously throughout her perinatal period, she will be followed, which will be entered in the computer, and it will be available in the every health center. So she can be followed in any health center if she enrolls her number in the primary health center, and the card will be given and the booklet will be given to her to follow it up. So it is important to check for the infections, anemia, obesity, hypertension, hypothyroidism, any kind of dietary indiscretion she follows, like excess intake of salt, sugar, caffeine, alcohol, any kind of substance abuse. So those should be prevented. They are all preventable causes. So injection Penadur, LA, that is 12 lakhs, benzathine penicillin is given at the interval of 4 weeks during pregnancy and preparing as a preventive measure. If the mother has a rheumatic fever or acquired illness, or she gets a frequent sore throat and all, it is important to protect from the infection. And counseling should be done regarding the prognosis and risk, and anticoagulants therapy is indicated if the mother has congenital heart disease, pulmonary hypertension, a mechanical heart valve implantation, or if she has a frequent atrial fibrillation. And the prerequisites required for the preparation and of the pre-pregnancy counseling for the patients with known heart disease. Why this? The optimization of maternal health is important. A woman with CVD should be evaluated with a cardiologist, as I told you before, and to assess the potential risk, and a complete history, a format should be, a high-risk format should be developed by each hospital, like a detailed history, including family, current cardiovascular symptom, a physical examination, and the review of medical records. So the person should be thorough with the the details of the mother, and comprehensive cardiovascular family history, any genetic illness is there, that also should be. These are the prerequisites which should be kept in mind. According to the European Society of Cardiology, they have given some principles which you should follow the antepartum period. They say that the mother should give birth in the hospital only, and no home birth is encouraged, and adequate resources is important. The manpower, the supplies, medications in every health facility. It should be there, should be anticipated, outlined, and documented. A comprehensive plan should be made along with the pregnancy heart team. It's important to record the fetal growth also, and daily dose of aspirin prophylaxis is recommended, which is initiated between 12 to 28 weeks of pregnancy. It is important for the health professional to explain each and everything to the mother, why she's taking these medications, how it will be beneficial, and important to note about the blood pressure. She can mark in her calendar or in the phone, like she can have a digital blood pressure machine with her, and she can record daily the blood pressure. Again, if there is any fluctuation happening, immediately she can approach the pregnancy heart team and get it treated. So this information is important to, it's a simple information. Again, fetal kick chart. Fetal kick chart also is important, where daily the movement she should record, and she can tick it in the phone calendar or in the calendar, manual calendar. If she has, she can tick it and keep it. If any alterations are found, the movements are less than 10, and if the normal blood pressure level is altered, so she has to approach the health facility as soon as possible. So this much level of knowledge should be there with the mother who has the cardiac illness. Then only we can prevent the illness. And prompt treatment of severe hypertension is important to prevent the complications. And she should carry the ID card saying that wherever she travels, says that she has a illness and she's under treatment, the emergency contact number. She should have the contact with the pregnancy heart team members, so that she should have to be carried in the ID card whenever she travels throughout her perinatal period, wherever she is. And intrapartum management is like the comprehensive individualized plan should be made. And women with a stable cardiovascular status, it has been said she can undergo a normal vaginal delivery under strict supervision or a cesarean section, which will be reserved for the obstetric instruction. And she can opt for regional anesthesia because that will reduce the, give a lot of pain relief. It minimizes the releases of catecholamine because that will have a significant effect on the cardiac output. It causes a lot of fluctuations in the cardiac output. So it is up to the pregnancy heart team to determine whether the mother can undergo the general delivery or she requires assisted second stage, shortening the second stage or whatever it is. So it has been up to the pregnancy heart team members to decide. And which should be explained to her. If you want to do the induction of labor also, again, the discussion should be happening with her and happening with the pregnancy heart team. And anticoagulation therapy should be properly, carefully reviewed and managed by the pregnancy heart team, because that can cause a lot of impact in the maternal outcome. And for the mother who receives this low molecular weight heparin, before the delivery means it should be discontinued 12 hours before, and after that 24-hour interval it is recommended with adjusted dose regimen, especially the people who undergo the mechanical prosthetic valve replacements. For those people, it is important to follow this anticoagulant regimen. Unfractioned heparin dose of 7,500 units subcutaneously twice a day, a 12-hour interval, as well as evaluation with the coagulation status and with the laboratory testing is recommended. So you have to manage the cardiac complications, which will include mainly the pulmonary edema and arrhythmias. So always the setup where you have the intrapartum should have the connection with the OT and the ICU, ICCO. It should be very nearby. So once if you are not able to manage them during the delivery, immediately the access should be there to the OT and they should be alerted, and the ICCU should be kept ready for the mother to tackle the complications. So intrapartum cardiac monitoring is recommended, and pulmonary edema can be prevented with the meticulous administration of IV fluids. And anesthetic principle, always you should have the anesthetic person in hand, and they should monitor the conscious level. and elevated level of monitoring is important, especially when the mother undergoes a DNC or evacuation or circulage or a cesarean section. So under the direction of the anesthesiologist, she should undergo the vaginal delivery, because epidural analgesia will cause a less strain in the mother. So the pushing part will be less and the pain received by the mother will be less. The effort on by the heart load will be less. So these things are very important to understand. And cardiovascular events, usually arrhythmia, are significantly released with this epidural use of anesthesia. So we should understand. So during the labor, people all might be familiar with the stages of birth and delivery, but when it comes to cardiac mother, we need a pregnancy heart team, obstetric heart team members to come into the picture, and they should help the mother to deliver the baby safely with less complications. And you have to induce the vaginal prostaglandin may be employed in selected cases, and the mother should be protected especially against the infection and the fluid overload. Position the mother in lateral ligament to minimize iodocaval compression. Oxygen should 5 to 6 liters. Analgesia is epidural, and prophylactic antibiotics to be given before starting of the labor itself. And fluid allowed is only 75 ml or as prescribed to prevent the pulmonary edema. And in you have to watch on the pulse and respiratory. It's important to have a student nurse, a learning nurse nearby, and there should be a midwife, and there should be a pediatrician, immunologist, heart specialist. All should be anesthetist. Everybody should be nearby. All should be watching the vitals of the mother. If it exceeds more than 110 between the contractions, give a digoxin of 0.5 mg. Cardiac monitoring and pulse oximetry to detect the arrhythmias and hypoxemia early. And central venous pressure should be monitored, and antibiotics should be prophylactically given as earlier I told you. And again, the intravenous ampicillin 2 gram and gentamicin 1.5 gram to be given at the onset of labor or induction of labor. And then in the second stage, this is the very important part where you never ask the mother to push. No maternal pushing, because pushing will cause strain in the heart. So it has to be shortened, curtailed by using the ventouse than the forceps. Ventouse is more prescribed because you can apply the ventouse even putting the mother without even in the lithotomy position, because lithotomy position again will cause a lot of strain in the mother. Nowadays we have a labor suit and we can tilt the in hospitals which doesn't have that labor suit can follow this. And intravenous ergometrin is contraindicated. We should not give for a mother with cardiac illness. Instead, oxytocin can be used to prevent the blood loss and have an effective contraction of the uterus. And the fluid loss is controlled by, overload is controlled by IV furosemide. Lasix has to be given. And usually vaginal delivery is encouraged for cardiac illness unless cesarean section in case of biaction of aorta, aortic dissection, aortopathy, like that. And there are many other conditions also where congenital heart disease. So everything goes on planned with the cardiac team. And surgical management, cardiac surgery can be in the pregnancies indicated if there is a failure in the medical treatment, if there is intolerable symptoms or intractable cardiac failure. So they are planned the surgery based on the grade 1, 2, 3, and 4. An emergency when there is a deterioration in the mother's conscious, or there is dyspnea, cough, basal crepitations, tachyarrhythmias and all. So based on that, surgical management is done to correct the illness. And management of the cardiac failure in pregnancies, give a proper position, oxygen administration, furosemide of 80 mg, and mechanical methods should be into the mechanical ventilation, and injection morphine 15 mg is given, and digoxin 0.5 IM followed by tablet 0.25. Then dysarrhythmias, if you find quinidine is given, and electrical cardioversion to be ready. If you find any dysarrhythmias, this has to be administered, and tachyarrhythmias are controlled with the adenosine. In puerperium, it is very important to observe the mother. It's a crucial period, more prone for a lot of complications. She has to be closely monitored with adequate oxygen to be administered, hourly pulse, BP, and respiration to be recorded. Very importantly, fluid overload should be controlled. Normally, diuresis will be there in the normal postpartum mother. And here again, the fluid overload chances are more edematous. Mother is edematous. So it is important to use the diuretics. And the breastfeeding is not contraindicated unless there is a heart failure. Anticoagulant therapy is also not contraindicated for breastfeeding. So the immediate postpartum principles why we should follow is, it has been the result study shows that 23% of death is postpartum death. Less postpartum death is found to be peripartum cardiomyopathy. So it is important to manage at the earliest. And Importantly, we have to check on the record of fluid balance, any shortness of breath mother has, any cough. So early consultation and early identification of this can be, the death rate can be prevented. Again, thromboembolism is a common killer. Okay, thromboembolism is a very important thing which should be assessed at the earliest, because the cesarean delivery in the postpartum hemorrhage or infection, that increases the chances of venous thromboembolism. So prophylaxis of enoxaparin should be given as a prophylactic measure. And in postpartum period also, the proper anticoagulation therapy should be followed. Like in antenatally, they take the heparin 5,000 units twice a daily, substitute up to 12 weeks, and it is then replaced by warfarin 3 gram, continued for 36 weeks during pregnancy. After that, the replaced by heparin in the postpartum period up to 7 days, and after that warfarin to be continued. So they are not contraindicated in the breastfeeding, so it can be continued. This should be explained to the mother. And it is important for the healthcare providers to learn the pharmacological considerations, because the mother has to take the cardiac drug, the pregnancy related drugs, pregnancy induced complication drugs. So many things will interfere. So it is important for the healthcare providers to understand the dosage, side effects, the nurse's responsibility, everything. So it should go hand in hand. So very careful administration of pharmacological management can help in preventing the complications. And contraceptive advice, the barrier method is the best one. And study says that progesterone only pill is found to be safe and effective for cardiac mothers. And though the IUCD, that is intrauterine copper device, is avoided for the fear of infection, the WHO allows guidelines allows the permits to use it. Permanent sterilization of the male and female to be considered. If the female has the complications more to undergo the abdominal route of mini lap technique, the male can be advised for vasectomy. Effective contraception should be advised. So the studies conducted by P. Faller in 2020, he says that 49% of these issues occurs, risk factors of mother with heart disease having such risk factors, that is provided management related factors occur. Why? Patient related, hydrogenic and system related. Why? What are all the reasons? But his studies prove that there is failure to identify the condition prior to pregnancy. There is failure to identify as high risk mother, late recognition in the cardiac deterioration, delay in the treatment and intervention, inappropriate treatment, and no preconception counseling. So many health centers I have observed, the doctors will not talk much to the mother. Mother will be ignorant. She will not know about what is happening in her body, why she is taking that tablet. So as a nurses, we should be there to fill the gap. Like we should be able to inculcate the knowledge what she has to know. So there are serious cardiac events can be prevented. So the role of the pregnancy heart team is to understand the level of risk in the mother, and they should have a counseling, undergo the counseling session, discussion with the mother about the potential risk of transmission of congenital heart disease even to the child, and they need to provide an increased medical surveillance during the prepartum period. That will be the important role. And these are the ad hoc members which every health facility should have in the pregnancy heart team. And pregnancy heart team, as explained by WHO, is for classification 1, you have an obstetrician, family medicine practitioner, internist, and cardiologist. And for classification 2, along with the practitioner, you have a maternal fetal medicine subspecialist. And the class 3 and 4, you can see the people who are increasing there: obstetric anesthesiologist, cardiology subspecialist in adult, congenital iotopathy, other illnesses. So as the risk increases, the members also it is increasing. So if we are able to adapt this pregnancy heart team prescribed by WHO, I believe that we can prevent the complications of cardiac illness in the peripartum period. And why we should do the risk assessment, why it is indicated, and what type of recommendation can be given, should be given to the referred centers. Why? Because you require competence, expertise in the obstetric care provider, and providers should be able to differentiate the common symptoms of pregnancy and those suggestive of cardiovascular disease. A lot of studies says that maternal mortality is raised up because the cardiovascular disease is undiagnosed, and most of the death occur because of peripartum cardiomyopathy, and all the mothers should be assessed for cardiovascular disease in the antepartum and postpartum period. So, and patients concerning with the symptoms and signs of cardiovascular disease should undergo the consultation with the heart team. So this is the chart that helps you to differentiate with the normal pregnancy symptoms and the abnormal symptoms. So here, for example, the green color shade says that it's a normal, and the orange indicates it needs evaluation, and the red color says that she has to be under the consultation, under the care of pregnancy heart team. Say, for example, I take one symptom like shortness of breath, none or mild, doesn't interfere with the mother's normal ADLS, no problem. She can go on with that, not to worry. But if it is on that she has moderate exertion, she has cough, but in that case, she has to be evaluated. It is important. But if the shortness of breath is there in the time of resting also, she has paroxysmal nocturnal dyspnea, orthopnea, definitely she should immediately contact the people, and she should be under the prompt evaluation. Likewise, you can go through the symptoms, how it has been done. So how to recognize what is the normal symptoms and what will be the abnormal one. And it is found to be, the cardiac obstetric team has found its more importance to prevent the complications. So what the cardiac obstetric team members will do, they be obstetrician, cardiologist, the maternal fetal medicine specialist, genetist, anesthesiologist, pharmacist, obviously the midwife. So they form a team and they go and they help the mother to have the proper pre-pregnancy counseling, and they help them to evaluate the preconception health evaluation and medication review. They assess the maternal cardiovascular disease. The continued discussion will be there, and the mother will be kept monitored during the pregnancy, and what kind of delivery, what type of delivery she can have, depending upon her risk level, what timing, whether it could be spontaneous or inducted, whether she need induction of delivery, under what level she can undergo. All this have been discussed under the team members, and peripartum cardiac monitoring also will be done, and she will be continuously monitored, and she will be helped to choose the contraception, and whatever risk factor she has as a cardiovascular, that can be modified with the help of this team member. So having such a team members in every health facility is important, and they will do the screening, and they will do the health education, and they will have a multidisciplinary planning, and they will have a discussion with the pregnant mother and their family to understand, make them understand what is the cardiac status, what will be the maternal and fetal outcomes. And here you get a complete picture. Like once you collect the details about the mother, you analyze the risk factor, what kind of is it increased age, what kind of race she comes under, is she obese, is she having any other cardiovascular illness, and then what about the symptoms, what are all the class she comes under, that and all you will undergo. Then you do the physical examination. If you find there is an abnormality, like a loud murmur or the heart, or for example basilar crackles, and the symptoms are there, she has to undergo thorough cardiological checkup, EKG level and BNP, echocardiogram, and the complete comprehensive metabolic profile, ABG, drug screening, everything should be done within a week. Okay, and after that, if you see that results are negative, she can be reassured and routine follow-up can be done. If you find that results are abnormal, then she has to be under the umbrella of pregnancy heart team members under the consultation of that. You should not make her upright, but at the same time, she understands that acceptance of the treatment is very important. So that part, midwife plays a very important role in health educating the mother, and they review the pregnancy heart team members. They review the risk benefits and alternative therapeutic options and continuity of medication. They encourage them to take the medications properly, especially the autonomy of the patient. Respect for the patient decision also should be there, and Also talk about the maternal and fetal hazards, that also is important, and collaborative discussion should be made. These are all the roles of pregnancy RT members. So how can you implement the proper nursing care, and how can you prevent this complication? Who can do? A midwife can do. A midwife plays a very important role. 90 to 100% she can give her contribution so that she can prevent the mother to entry level of cardiac illness can be prevented. Because she's skilled, knowledgeable, she provides a compassionate care for childbearing women, okay, and a newborn and the families across the continent throughout the perinatal period. And her core characteristics will be providing a maximal biological, psychological, social, and cultural process of reproduction in early life. And she gives a timely prevention and management of complication with consultation and referral to other services. So it is important to enhance the midwifery, to optimize the midwifery. That is the central core theme of this conference. And who is a midwife? A midwife is a person who successfully completed a midwifery education program that is duly recognized in the country where it is located, and that is based on the International Confederation of Midwife competencies for basic midwifery practice and framework of ICM standards of midwifery education, and has acquired requisite qualification to be registered and legally licensed to practice midwifery and use the title of midwife, and who demonstrate the competency in the practice of midwifery. And why do we need midwifery in every country, especially in India? Why do we need? You can say that the studies have proved that there is increased availability of quality and maternal newborn health services possible, and this has been aided to the reduction of maternal and newborn mortality and morbidity. So definitely every country should have a adequate number of midwife so that they can provide a proper referral according to the class of risk, and they can do all the appropriate, help the mother to do all kind of diagnostic tests, and she can be counseled to avoid the pregnancy or undergo the preconceptional counseling. And the objective of having the midwifery services, optimizing the midwifery services, is to provide essential quality maternal and newborn health services and promote natural birthing by promoting positive childbirthing experience, promote respectful maternity care throughout pregnancy and childbirth, identify, manage, stabilize, and refer wherever needed the women and newborn experiencing complication, to decongest the high level of healthcare facilities, to expand the access to quality maternal and neonatal services, even in the remote areas, including the pockets of high home delivery rates and urban slums. So, also, what is the role of midwife? She is a knowledge person, isn't it? She gains the knowledge. She need to update her knowledge. So she is familiar with the signs and symptoms. So she is the primary person who can help the mother to improve the and she can educate and create awareness, okay, to get evaluated by cardiologist before pregnancy as early as possible. And she is a caregiver. That is her role. Okay, she can do a nursing process with the appropriate implementation of nursing care by diagnosing, assessing the cardiac illness at the earliest. And a care manager, she can be a care manager. She can give a multidisciplinary care in accordance with the pregnancy heart team, and she is an effective communicator where she can communicate the illnesses among the team members, and she can coordinate the care, okay, with the pregnant mother, and she can help. She can be of a great help to reduce the maternal morbidity and mortality level, and she can help the mother to continue the pregnancy with the reduced complications, and preventing the complications as a caregiver, primary level, secondary, and tertiary. Primarily, we do the pre-conceptional counseling, planned parenthood, high-risk assessment, early screening, prophylactic antibiotic, plan for safe confinement, health promotion, prevention, and restoration of care before the disease enters or before the signs and symptoms arises. She can give this much care. And secondary, she does the early screening of the cardiovascular status, and she helps to consult and follow up with obstetric and cardiac team members, and frequent antenatal strict follow-up, treatment of signs and symptoms in high quality hospital and planned parenthood. She helps for the grief and the bereavement, where the mother will not go for a postpartum depression because of the fetal loss if the mother has. And tertiary is like a mother who comes under the class 3 and 4 risk, where she is trying to prevent the complication, restoring the ADLS with the disability, and having a grief and bereavement sessions, okay, so that she can adopt a normal life, and she can go help the mother to suggest for adoption or for having a proper planned parenthood. How to optimize the midwifery services. We have to act, monitor, and review. What is there in the act? The WHO says it is important to strengthen our leadership and policies, okay, and gather the data and evidences about the pregnant mothers who is having the cardiac illness, and build a public engagement and advocacy. Prepare the educational institutions in such a way, and they practice the settings and the clinical things properly, okay. So they strengthen the faculty and standards and curriculum, and educate the students, thereby you are able to monitor. And how to review is monitor and evaluate, review and adjust. So by this we can be able to optimize the midwifery services, so that all midwives are educated to high standards and enabled to practice their full scope, and they're involved in education policy at higher level. That's very important. Involving them in educational policies, they get a place to tell their problems at the high level, and education process should be coordinated and aligned. So as WHO says, there is a resolution to optimize the healthcare. As the last year, 2020 was the year of midwife, where they are really invest, and then the theme of nurses day was to invest in nurses, okay, invest in midwife, so that she gives more improvement to the sexual, reproductive, maternal, newborn, adolescent healthcare service. So you have to invest in midwifery, so that there is a midwifery leadership and governance is enhanced, and invest in high quality education and training of midwife, invest in health workforce planning, management and regulation in the work environment. Thereby the capacity building of the nurses workforce is increased, and so that there is a strong interdisciplinary health team is being formed in the every health institutions. The action plan is like the study says that 80% of maternal death is prevented once the midwife undergoes an international standard of education, where she is licensed, regulated, fully integrated to the health system, and she is able to prevent the a lot of improve the 50 or other health related outcomes, including sexual reproductive health, immunization, breastfeeding, tobacco cessation in pregnancy, malaria, TB, HIV, obesity in pregnancy, and early childhood development and postpartum depression. This much contribution she is able to do. And midwives are uniquely able to provide the essential services to the women and newborn in the most difficult humanitarian, fragile, and conflict-affected settings. Astana Declaration in 2018 says that midwives will make a significant contribution to deliver the commitments so that there is a health for all as a global action plan. Educating the midwife to international standard is always cost-effective investment, as it saves the resources by reducing the costly and unnecessary interventions. Yet there is a startling lack of investment in the quality midwifery education. So it is a time for us to take the collective action. So here there is a WHO interpartum care model, where we need essential resource forces, a competent and dedicated staff, so that they provide a respectful labor and childbirth care, emotional support from the companion of choice, provide effective communication from the staff, pain relief strategies, options are given to the mother, regular labor monitoring, documentation of events, audit and feedback, proper intake of oral fluids and food intake, mobility in labor and birth position of choice, pre-established referral plan and continuity of care. If they are able to receive this minimum resources from this interpartum model, the maximum complications can be prevented. And as a nurse researcher, the research findings say that 32% of maternal heart deaths due to heart disease can be prevented. They found out the reason is a lack of multidisciplinary care. No customized local guidelines are given, no uniform distribution of healthcare facilities, and there is a poor awareness, especially among the public and healthcare providers and policymakers. They become the predominant reasons. So the significant number of maternal death can be prevented. There is a proper multidisciplinary care which can be targeted to deliver the improved healthcare. Again, the latest guideline provided by European Society of Cardiology also recognizes the importance of preventing the complication of cardiac illness. They also given many information about the potential service and registries regarding the management of women with the heart diseases. And another research done in Tamil Nadu, conducted by Justin Paul Jnanaraj, started in 2020. Still the study is going on. It's an excellent study which I come across, but which interested me is like they got permission from the government of Tamil Nadu to create a nodal centers in all the states, where they will be preparing a multicentric, multidisciplinary registry for pregnant women with heart disease, where they will be screening each and every woman with a cardiac illness, and they will be able to identify. Every state will have this nodal center, and this nodal center will have a very good, excellent pregnancy heart team members, and they will be supervised by a separate person will be appointed for supervising those nodal centers. Okay, and these heart team members will screen and assess the mother separately, and they will be put under the care, and they will be able to, this study will help us to understand what will be the outcomes, fetal outcomes, maternal outcome, why there are more complications, what can be done to prevent the complications. So such a study is still going on. So they will be able to identify the gap in the existing healthcare delivery, and it will initiate the step for capacity building and empowerment of healthcare workers and institutions to ensure the delivery of quality cardiac care to the unnatal mothers with heart disease, and formulate the practical and applicable guideline for management of pregnant women with heart disease. So this is what the study was telling. So it was very interesting. All can go through it, which will help. Even every state should follow, should have a nodal center for such illness. So I hope I have covered the session. Thank you.
Thank you very much to Dr. Nisha Clement for the interesting and amazing materials, which is perspective of prevention and reduction of complication of cardiac illness in perinatal period. Thank you. And now we are entering the question time session. So we have collected questions from the chat box here. I will read one by one, and then I would like to ask to Dr. Nisha to maybe give the answers. Excuse me, could you please stop your screen?
Yeah, sure. I'm going for that. So stop that.
Yeah. All right. Okay.
Will mothers who have a history of heart disease affect the growth of the baby? Definitely. It will affect the growth of the baby because, as I already discussed, the physiological changes that will happen in the heart and the vascular system. So because the strain in the heart is very high and the reserve power will be less. And definitely blood supply, because the fetus is dependent on the mother, right? So 100% circulation is important, and definitely the growth of the baby will be affected, and baby may be having a congenital illness also. Chances of congenital illness also is more, and sometimes we may lose the child, and it will go for intrauterine growth retardation, IUGR, and we may lose the child. I'll go for the second question. Is that okay?
Excuse me, ma'am?
Shall I go to the second question?
Yeah, I will read one by one questions.
Yeah, I can read, no issue. Can doing an ANC examination on pregnant woman reduce the percentage of heart disease complication in the perinatal period? Doing examination is important. Doing examination is important.
Okay.
Whether it will reduce the percentage of heart disease complication is a questionable. Like you have to examine the mother. It's must actually. Why you do examination is to find out if there is any abnormality, deviation from normal, isn't it? So when a mother is having a cardiac illness, definitely there will be a significant difference in the growth of the fetus. Okay, significant difference in the growth of the fetus, growth and development of the fetus. So it is very important for us to understand whether they undergo the normal growth and development. So ANC examination is important, which will help you to alert from the early complications of heart illness. So that thereby can prevent to some extent of complications in the perinatal period.
Okay. Okay.
Can I go to the third question?
Yeah, actually, I have a question, ma'am. May I?
Sure, sure, sure. Tell me.
Thank you. So I've seen on your presentation, on your slide, there is a triangle blue. I saw that the age and human race is also has a role significant to.
Yes.
Yeah.
They have found study on that particular race, the particular genetic race. They have proved, studies have been proved. That's why that they come under risk. I understood what you have asking. Yeah, several studies have proved like that. There is no definite reason why they get.
Okay, thank you. Thank you. Maybe we have
another question I have seen here. Can I go through that?
Excuse me?
A third question. Can I see that the third question? Shall I answer?
Yeah. Yeah, I got your answer.
Yeah. Can a pregnant woman who have heart disease not to give birth normally? It's not like that. She can give birth in a normal birth, provided she is under a cardiac obstetric team members, and it depends upon her classification. If she comes under the modified WHO classification 1 and 2, she can undergo the heart disease provided she is under continuous treatment and monitored. She's been monitored properly. She can undergo a normal delivery. And again, it depends upon the decision with the cardiologist. Okay, and if the lesions are more and if her heart is not able to tolerate, she has to go for cesarean section only.
Okay, thank you. That's the question from Nanda Afrianti. Thank you very much for the answers.
Okay.
Maybe we have another questions.
Yeah.
So this is from Wahyuni Mohune.
Okay.
If the mother has a heart problem, will the baby also experience the same problem as the mother who has a heart disorder?
The studies have proved that the mother has congenital illness, rheumatic illness also, the chances of the fetus getting is more. So that's why we advise them to do a genetic consultation. So there are specific genetic markings which will show the prevalence of getting more fetus with the congenital abnormalities. There are specific genetic tests available. She has to, that's why I'm telling in the every slides like preconceptional counseling. She has to undergo a preconceptional counseling, karyotyping test she has to undergo to find out the genetic abnormalities, whether the child may get any abnormalities that can be pre-screened, and she can be told if she gets continuously the same baby, it is a loss for her, right? She invests her time, money and everything to carry the child, and she is getting a child with abnormality. So it will be difficult, isn't it? So better to undergo the genetic consultation is important. And there are 100% chances for the baby to get. The studies have proved.
Okay, thank you. And the next we have questions from Sutriyani. what causes heart disease to occur during pregnancy, and is pregnancy with heart disease associated with an increased risk of maternal and infant morbidity?
Well, can you tell one more time? Like, can you repeat the question?
Okay. Question from Sutriani. What causes heart disease to occur during pregnancy, and is pregnancy with the heart disease associated with an increased risk of maternal and infant morbidity?
I didn't get the question, and really.
Oh, so you've answered that question. Excuse me, because
what will happen to the pregnant woman who have history of heart disease? Is it that?
Yeah.
Astri.
Yeah.
Astri. Okay. Well, what will happen to the pregnant woman who have a history of heart disease when they give birth normally? And what should we do to prevent this from? Normally, if she gives birth, then why you should worry? You should be happy, no, to give birth. If the mother is able to give birth normally, but she can prevent the further pregnancies. Like, she should undergo the contraception methods, effective contraception, because she should not strain her heart. Okay, so better to avoid the next pregnancy will be my answer. What will happen to the pregnant woman who have a history of heart disease when they give birth to normally? I told no, she can undergo a normal delivery if she comes under the risk classification of 1 and 2. She can undergo, because we have a very good obstetric team members with us, and they will shorten the second stage of labor, and natural birth can be possible for them. What you have to think forward is the contraceptive method to prevent the do a permanent sterilization after that, because further pregnancies can strain the heart.
Okay, thank you. Next we have question from Icha Patricia. She asked about can doing an ANC examination on pregnant women.
I told this actually. No.
Yeah.
I have answered.
No, I read from the chat box, ma'am.
Okay. What will happen to the pregnant woman who have a history of heart disease when they give normally?
Yeah.
I'm not getting the question.
Yeah, from Astri Adestin Ilimullah. What will happen to pregnant women who have a history of heart disease when they give birth normally, and what should
and she can give birth normally, no issues, provided she has the adequate I think I have answered this question. She should be under the consultation with the cardiologist and obstetrics, and she should undergo delivery only in the tertiary care level hospital, where it has high team members. And to prevent from happening means she should not deliver further. For the second and third delivery should be avoided.
Okay, thank you very much for the explanation. And next we go to Icha Patricia Ali Bugis. She asked about, can doing an ANC examination on pregnant women reduce the percentage of heart disease complication in the perinatal period?
It reduces as such as if you report it, timely reporting and timely deduction. As I told you earlier, early deduction, early examination can prevent, because when you do examination, you will be able to identify what is normal and what is abnormal. Okay, it is the time. Okay, the timely prevention is can directly prevent. It can reduce the percentage of heart disease and complications, definitely.
Okay, thank you very much indeed. So, do we have any extra time? Or okay, I think that would be the last question, and it signs us that our meeting will be end in few minutes. So I would like to represent our highest leader of Health Polytechnic Gorontalo to say thank you very much to Dr. Mrs. Nisha Clement, and I would like to represent our head of the midwifery major program in Health Polytechnic of Gorontalo to say thank you very much indeed to you, ma'am, for attending our invitation, and maybe in the next series of ICMHS we could be gathered together. So I would like to announce the certificate of appreciation, which will be given to you, ma'am. This is the certificate of appreciation.
Thank you, Rehman Sulaiman. Thank you.
Yeah, thank you. And this is it's been accredited by EB. And yeah, thank you very much. I ask your forgiveness.
I would like to thank Rehma Devi for following up me and carrying out all the procedures for this presentation. A special thanks to Rehma Devi.
Yeah, yeah. I lost you. Okay, maybe we can send you an email if we would like to ask your availability to the next series of ICMHS.
Sure.
Thank you
Sure.
very much. Thank you very much indeed.
Thank you very much. Thank you.
Yeah, and ladies and gentlemen, this is the end of this season of the second ICMHS 2022. Thank you very much for attending our invitation, and Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Mr. Rahman and Mrs. Dr. Nisha Clement, Associate Professor from India. And now to our questionnaires in the third plenary session, Mrs. Fitri Rahayu Rifai, Mrs. Icha Patricia, and the last, Mrs. Nanda Afrianti from the represented committee ICMS 2022 will get contact to give your interesting prize. Thank you. And then, with the end of all speakers today, on behalf of the organizing committee, I would like to thank you, the speakers, and all participants who have participated in today's activity from this morning to this afternoon. The activity will continue tomorrow with amazing speakers, and we need to inform you that the activity will start at 8 o'clock Central Indonesia time. So the all participants can join the Zoom meeting room 5 minutes before the event starts. And for your information to all participants, tomorrow will also be followed by oral presentation and poster presentation from participants who have registered. And tomorrow it will also be announced who will get attractive prize, who will get interesting prize from the committee. So stay tuned. And finally, thank you. See you tomorrow. Have fun. We all stay healthy always. Wassalamualaikum warahmatullahi wabarakatuh. Good afternoon.
every